What I'm going to do in the 10 minutes is talking about whether the SMBG in Ramadan is necessity or luxury. For those who they have something else to do, I can tell you from now, it is necessity. But let me take you through the presentation. So I hope you see my screen well and you hear my voice as well. No disclosure related to this presentation. I'll just take you through those items on the agenda, like brief introduction, ADA, SMBG in Ramadan, that will be mainly about the Dar recommendation, and just a bit of technology at the end and whether that will help our frontliners and our patients, and I will finish by the decision. So when we talk about the self-monitoring of the blood glucose, and that's the SMBG, all of us know it's an educational tool, and that when we have any educational tool, that should be used in conjunction with the diabetes management action plan. So if you have tools there for you ready to use, you should use it. So it's very important that the patient got educated about the technique and targets, otherwise it's useless. The other thing, when it comes to the recommendation, it's like medication. Sometimes when we ask patients to go and do self-blood glucose monitoring, we don't guide them about the frequency and timing. So it should be guided when it comes to the frequency and timing, because one size doesn't fit all, and patients on different medication or insulin therapy or Ramadan timing, the frequency and the timing can be different in different patients. Again, it's a good tool to identify the hypoglycemia and hyperglycemia patterns, so it guides us how we manage our patient. Very important when it comes to us healthcare professional, when we follow up our patient, when we look at the results, we have to make sure that we act on it and educate our patient, because that's an additional information to guide us in managing our patient. So as general principle, in my opinion, and from the evidence I'm going to show you, all patients who have diabetes should perform SMBG. The difference, of course, what stage of diabetes they are, what type of diabetes, what anti-diabetic medication, that's make the difference when it comes to the frequency and timing. The other thing, again, as I said, the need should be individualized, as I have explained. The other important thing is that the information or the data obtained by the patient and the healthcare professional to make the management decisions. So sometimes some patients, they bring their whatever booklet or their glucometer, and nobody asks to see that in the clinic. And some of the patients said this. So we have to make sure, we have to look at them, and we have to make sure that we make decisions on those. The other important thing is to make it cost effective and to tailor your medication. The SMBG is really, really important. Patients with diabetes have the right to know their glucose levels at home and anywhere, so that gives them more confidence. Of course, there are barriers to improve the outcome with the SMBG. Still, the access to supplies are limited when it comes to the availability, insurance, out-of-pocket expenses, language sometimes, because not every technology having most of the languages, and especially in the different Islamic countries, the adherence to the SMBG. Education is very important, because technique itself, just simple thing like alternate sites, frequency and time of testing, adjusting the diet and medication response to the SMBG profile is really important. Those still barriers to improve the use of the SMBG to improve the outcome. So the other important thing is that the patients, sometimes they are really fail to use it in proper way. So those are a few examples of the common user error when it comes to the glucometer. So failure to store strips properly, insufficient blood, no controls, out-of-date solutions, out-of-date strips, and failure to set meter code to match the strip code. So here where the education is very important. Failure sometimes in some glucometer to clean the optic surface for certain meters. So when it comes briefly to ADA, and I choose the monitoring here, and we use this for sometimes, the goals are very important in the targets. So we know even in Ramadan and before Ramadan, when we stratify patients, this is very important to know their HbA1c and whether they're in goals or not, preprandial and postprandial target as well. ACE is bit tighter, 6.5 or below, and fasting is below 110, postprandial is 140, and inpatient is not much relevant to this tool. So the ADA standard for SMBG, and I'm talking about the general management of diabetes, not particular in Ramadan. So those who they use multiple injection or pumps, they have to test prior to each meal, bedtime, prior to exercise, hypoglycemia, prior to critical tasks such as driving, to make sure they don't have hypoglycemia while they are driving. So SMBG is also useful, a guide for less frequent insulin injection, not necessarily they are on multiple daily injection or non-insulin therapy. They are still useful, and I'll show you some trials in a minute. When prescribing SMBG, we have to ensure patients receive ongoing instruction and evaluation. That will make the tool more useful. So those are the randomized trial in type 2 patients, okay, who they are not on insulin. So there are quite a few of them. And just to make it sort of easy and short because of the time, although it didn't affect or it didn't reduce the A1C significantly, however, it reduced the hypoglycemia. So those who they are using insulin here, the non-randomized controlled trial, they are at least trial were consistently showing a relationship between SMBG and A1C reduction, which is good. Still A1C reduction range, like it's not in some study, are not significant. Those who they are not using insulin, the non-randomized trials are over a dozen studies, most showing no relationship between ANC and the SMBG. There are a few meta-analyses, but the outcome here that when it comes to the hypoglycemia and the pattern and how you adjust the medication, it's positive in all trials. So when you have SMBG, of course, there are prerequisites with the diagnosis, knowledge, and skills. Then you make the interpretation and the response, and that hopefully will lead to good consequences, which is they achieve good glycemic control, reduce the complication, less symptom distress, improve quality of life, and improve patient. So let me now take you to the SMBG during Ramadan. So this is what the DAR guidelines ask us to do or guide us to do. You can see the more frequent whatever SMBG is the latter half of the day. So this is where the hypoglycemia event is the most. So it's pre-dawn, morning, midday, and mid-afternoon, and pre-sunset, then 2 hours after iftar, at any time when the patient have any symptoms. So when you look at the role of SMBG during Ramadan, of course, we divide patient not to fast or allowed to fast, and those who they have very high risk or high risk, the frequency of the SMBG, if they decide to fast, they have to do frequent SMBG, and that's several times of the day. Of course, the frequency for those moderate or low risk, 1 or 2 times a day is enough. All patients should break their fast if the blood glucose is 70 or below, blood glucose is less higher than 300, or symptom of hypoglycemia or acute illness. So when you look at that's the target, okay, before sahur, 100 to 140, midday is 140 to 80, and pre-iftar is 70 to 110, and 2 hours after iftar is 180 or below. And those targets the patient should know about, and this part of the education. And if they don't have the target to work on, the use of SMBG can be useless because there's no direction. Of course, lots of people doing exercise during Ramadan, and some of them do it before they iftar, so they have to make sure that the blood glucose target should be between 100 and 140 prior to any exercise, and snack first if the blood glucose below 100, and they have to monitor blood sugar 1 hour after they exercise. It's just one one or two slides about the new technology, the CGM. I know there's another talk tomorrow about it, but we found it quite useful because sometimes the SMBG lose the points. So you can see hyperglycemia not detected or hypoglycemia not detected by the glucometer, usual glucometer, the SMBG. And you can see different A1C with different time and range when we have the CGM, and we use that quite frequently these days. So we know with the glucose meter limitations, the asymptomatic episodes of hypoglycemia may go unreported. And we know that lots of cohorts of type 2 have almost 50% experience of hypoglycemia in 5 days period. And that's quite important to keep in mind. So with the CGM, okay, the different devices, you have much more data, plenty of data, and that showed you exactly the pattern and showed you the time range, the high and very high, and again, the pattern during the day, and that can add lots when it comes to tailoring the management for diabetes. When we train our eyes with those forms, it's really become very easy because if you use the AGB, you can see those. So for example, the first one is not that difficult because patient number one, you know, is not flat, not narrow, not in range. That's easy. The second patient, you know, it's flat, but not narrow and not in range. The second one, you know, it's flat, narrow, but not in range. And of course, the last patient, the ideal patient, flat, narrow, and in range. So it's like the ECG. As soon as you get to train your eyes to do it, it becomes very easy. And here, if you look at those three patients, okay, although A1C is 6.7 for all of them, you can see the profile is different. And there's a fluctuation. And the third patient at the bottom, and more, and a sort of, again, with the middle patient. And you can judge the first patient on hybrid closed loop, and the second patient on insulin pump, and the third patient on the insulin injection. So I think in the future, for those who they probably using insulin, the CGM will add a lot of safety when it comes to Ramadan and fasting. So at the end, I will summarize and conclude the timing of monitoring of the blood glucose during Ramadan, and you can see the difference between the normal days and the fasting days. Patients should make sure that they break their fast if they are below 70 or more than 100, or they have symptoms. And the question I have started with, or the title, is SMBG in Ramadan, necessity or luxury? And the answer to this is SMBG in Ramadan, a necessity. With that, I would like to thank you very much.